asked me to talk about pulmonary hypertension, and I thought probably it's a humongous topic, so I thought I'd probably just see if there's particular areas that you guys wanted to really talk about, or kind of a general look and then focus on the ICU management of these kids.
That sounds good. Yeah.
So I guess a nice place to start is what is pulmonary hypertension? And certainly it's kind of a general definition. All it really implies is that the pressures are high in the lung. The formal definition by the AHA guidelines, so it applies to the adults and kids, is that by cath, the mean PA pressure in the pulmonary artery is greater than 25. And then the wedge pressure, which is really an estimate of the left atrial pressure, needs to be low or less than 15, because you want to make sure that it's just related to the lungs, not to the left side of the heart. And then the third part that used to be part of the definition is the pulmonary vascular resistance, which is really just a marker of resistance, like physics class in high school. There's a unit, which is a Woods unit, that has to do with the resistance through a tube. And so usually the resistance needs to be greater than 3. Those are just sort of numbers at the end of the day. You can forget all those, but so that you know that people do technically have formal numbers that we follow. And so for the other thing that's important about pulmonary hypertension, not only is the definition, is the type of pulmonary hypertension. And for here, we see a lot of post-operative pulmonary hypertension. I think that's probably what everybody's the most comfortable with up here. There's certainly other types that they see more so in the outpatient world. And those types are more related to either lung disease, so certainly the NICU sees lots more of that. In kids that would be premature kids that also have pulmonary hypertension related to lung disease. And then we also see kids that have pulmonary hypertension related to chronic thromboembolic disease. That's really an adult disease as well, so they get blood clots, and the chronic blood clots then change the lung vasculature, makes the pressures high. And then there's a third type related to connective tissue diseases, which we don't see a lot of in kids at all. And so that's people with things like lupus, Sjogren's, sclerosis, things like that. Over time, they also develop pulmonary hypertension because the connective tissue disease also affects those small vessels in the lung. Usually takes about 15-20 years for that to happen in those diseases. So certainly on the adult side, when I work on that side, these are the ladies that are sort of 45, 50, 60, 70 that come in with bad pulmonary hypertension related to their connective tissue disease. So there's kind of some different groups that we don't see a lot of here. Certainly in the ICU, we see a lot of post-operative, and we see a lot of congenital heart disease with associated pulmonary hypertension. So those are kind of the two big groups that I think we're focusing on today. So that's sort of the etiology. It's important. The one thing in terms of deciding why the pressures are high in the lungs, the most important thing from an ICU standpoint, is making sure that it's not related to left-sided disease. And I think it's just kind of nice to go through that pathophysiology just to make sure that everybody's clear why it's so important. And so the biggest thing is that if it's related to left-sided disease, so an example would be something like mitral valve stenosis. So the mitral valve is tight, so the pressure then, as you imagine, it's just plumbing. The pressure gets high in the left atrium, the pressure then gets high, it backs up into the lungs. And so the pressures are really high in the lungs because the mitral valve is too tight. And so you imagine if we look at those kids and we treated them the same way as we treat everybody else who we think the pulmonary hypertension is just related to the lungs, it doesn't really work very well. We're giving these kids nitric oxide and all these things to dilate the vessels in the lungs, which if the problem is really the mitral valve, if you're not doing anything, all you're doing is making those lungs worse by expanding the vessels in the lungs. So it's really important from stage 1 when you're treating a kid with pulmonary hypertension, you have to have asked yourself, is it left-sided disease or is it not? And I think that's a pretty important thing. And the other group I think we see more of up here is pulmonary vein stenosis. You'll hear us always, with a kid with bad pulmonary hypertension, we're always asking, is there pulmonary vein stenosis? And you'll see us do echo number 3, number 4, number 5 to look at those darn pulmonary veins. And you guys are probably wondering, well, why do they actually care? What's the big deal about this? And the big deal is that if they have pulmonary vein stenosis and we put them on nitric, then we're just going to make them much worse. Because again, we're expanding the lungs when really the problem in the narrowing is really the pulmonary vein. So it's a very important differentiation to make. So you'll see us kind of in the diagnosis phase make sure we're ruling out that part out, and kind of left side disease, pulmonary vein disease, and really making sure that if it's true pulmonary hypertension, it has to do with the vessels in the lungs. So that's the important part of a diagnosis. In terms of the kids we see in the ICU, certainly the most common ones are those kids that have either a genetic disease. An example would be those with trisomy 18, trisomy 21. Those kids are at prime risk of developing post-operative pulmonary hypertension. And why? I don't know if we actually know right now. I think it has to do particularly with how their vasculature in the small vessels, so the small vessel lung disease is happening. And we're getting better at that, but certainly those patients are all identified. And you guys know the children with Down syndrome or trisomy 21, certainly post-operatively we're all a little bit on our toes looking for pulmonary hypertension. The other group that certainly you need to be aware of for post-operative pulmonary hypertension is the kids that have had lesions where the lungs have been exposed to high pressure. And So an example, classic example of that is a VSD. So a big VSD that's treated late, PDA treated late, AP window treated late, and I think we've had examples of all of those. They come at least 2 or 3 a year where kids have been diagnosed quite late, and we are always worried about hypertension after the surgery stuff. So those are kind of the big kids. There's a whole bunch of other kids, of course, that we're always worried about. The total anomalous veins are also another group where we're kind of a setup for pulmonary hypertension, but then again, those are hard kids because it's a mixture of both the vessels and as well risk for pulmonary vein stenosis after the repair. So another big group to at least put on your list. Management, I think you guys, it'd be nice to talk a little bit about management. From our standpoint, the diagnosis of pulmonary hypertension ICU is a little bit different than in the clinic world. So in the clinic world, you can rely a lot more on echo, x-ray, of course your clinical exam, and then cardiac cath. In the ICU, we can't just bring everyone to the cath lab. So we have to use some of our other things that we have available. Of course, a PA line is beautiful because that tells you exactly what the pressures are, but we don't use a lot of PA lines in this unit. So without a PA line, then you're stuck using your other things that you have for you. And of course, you'll see us talk about the CVP and the left atrial line or the tracing of those two, because we find that with pulmonary hypertension, as the pressure goes up in the lungs, then the CVP, of course, will go up because the pressure becomes higher on the right side of the heart. And you won't see that same increase in the left atrial line. That's a nice way to use your lines. Clinically is probably the nicest way to diagnose pulmonary hypertension in the ICU, and you'll see us looking at these kids. The biggest, most important thing I think you probably should take home, pulmonary hypertension, for them, if they have a spell, the pressure goes high on that one side, and of course what we're worried about is there's then no blood flow through the lungs. So you can imagine you have two options in the body. If you have really high pressures on the right side, and you have a residual pop-off or a hole between the ventricles and the atrium, of course the high pressure on the right is going to push that blue blood over. So the kids that have a residual ASD or residual VSD, when they have a pulmonary hypertensive crisis or high pressures in the lung, we're going to see them turn blue. But if you have a kid that doesn't have that, so the nice VSD that was completely repaired has no ASD, when they have high pressures in the lungs or a pulmonary hypertensive crisis, then the blood can't shift over, so they don't actually turn blue. So it's kind of a really nice, important thing from us. You always ask us, you'll hear us say, is there a residual PFO in the surgery? Did you leave us a residual ASD? What did you leave us? And so we're asking that because we need to know if this kid has a pulmonary hypertensive crisis, are they going to turn blue or not? And if there's no residual holes, there's no way for them to turn blue. So it's an important thing to differentiate, and you'll hear us talk a little bit about that as well. Those that don't have a residual hole, of course, their presenting is going to be hypotension because they just don't have enough blood going back to the left side of the heart. So I guess there's kind of two groups, and it's nice to differentiate them. Those with residual shunts will turn blue because they can push the blue blood into the red blood side, and those without any residual shunts are going to present primarily with hypotensive. And I think most people in this room have had a kid where you thought, they're almost a little bit spelly and they have a little bit of issues, and if they have a residual lesion, then they'll turn blue with their spells. If they don't have a residual lesion, then they'll have more hypotension with it. And those are the ones often I think get missed because we're waiting for the kid to turn blue, because that's usually what we see. But remember, if they don't have a residual lesion, they won't turn blue. So those are kind of nice things in the ICU just to look at the bedside. Everybody's had one here. They're pretty twitchy kids, and that has to do with, again, as they get upset, the pulmonary vasculature naturally will clamp down on any kid that gets upset, and it tightens down. And so a kid that already has high pressures in the lungs, they get ticked off, and then their lungs get tighter. You can imagine the pressures even get higher. So that's sort of the nice way to think a little bit more about them. They're usually very twitchy, usually short spells. It comes on fast, and we'll talk a little bit more about management, but can present with blue cyanosis, or you can present with hypotension. So the management, I think you guys, most people have had the pleasure of having one of these kids after. Usually the first 24 hours is the worst period with them because their pulmonary vasculature is not only twitchy from the surgery itself and the bypass run, but they also are usually in their most unstable period after a surgery anyway, so they're pretty difficult to manage the first 24 hours. The nicest place to start is conservative management. If anybody has seen us do, we try to stay with conservative first because, of course, it's cheaper, and we're sort of starting at the bottom of the totem pole. And some of the things that most people will use is sedation, of course, to keep the kids settled. Oxygen, it's a very cheap drug, and certainly the best thing that oxygen is really our best pulmonary vasodilator, so it expands the vessels of the lungs, but does not actually affect the vessels of the system as much. So we like oxygen, we like sedation. You'll see us with the ventilator try to make the kids a little bit alkalotic rather than acidotic, and that helps because a little bit of alkalosis also provides some pulmonary basal relaxation. So again, we're all focusing on expanding the lungs of the vascular bed. And so those are sort of three nice conservative things that you'll see us try for the kids. Paralysis comes in, of course, after sedation, with the idea that if they are really, really twitchy, paralysis kind of settles them out. Certainly it's not a long-term solution by any means, but it's a nice option for that first 24-hour period when they're really, really twitchy and unsettled. So those are some of the conservative things. After that, looking at medications, technically you could put oxygen as a medication because it truly is one. And really you'll see us using FiO2s more in the higher range. So I like to think of oxygen as a drug in these kids because when you're using an FiO2 greater than 60%, you're exposing the kids to a risk of oxygen toxicity. And so I think it's really important to remember that oxygen, though it's easy to use and easily available, it certainly is a drug still. So you'll see us use higher FiO2s, usually greater than 60%, just to help settle these kids down, and again, use that oxygen to vasodilate the pulmonary vascular bed. Other drugs, there's kind of three mechanisms that we target, and all of those mechanisms have to do with managing the smooth muscle of the pulmonary vessels, the pulmonary vasculature. And so there's kind of three pathways, and just in general, there's a nitric pathway, there's a prostaglandin pathway, and then there's another pathway that's run through the endothelial receptor antagonist. And so that's kind of our three main pathways, and all the drugs work on those pathways right now. In terms of the ICU setting, probably the most common one that people see after oxygen is nitric oxide. And that's usually our go-to because it's very nicely delivered. It goes right to the lung bed, so it's going right to the vessels that you want dilated. And doesn't have a lot of, because we're delivering right to the lung bed, doesn't have a lot of hypotension associated with it because we're just really dilating the vessels of the pulmonary vascular bed. So nitric, though, is very, very expensive. It is a very wonderful drug for that. There are some alternatives for inhaled drugs. We like the inhaled drugs, like we just spoke about, because it delivers it right to the lung bed. So other than nitric, we've used inhaled iloprost, and we did that for about a year here in the unit. And what we found, actually, though that drug is a little bit more difficult to administer, it has the same results as nitric oxide. So that drug may be making a reappearance in the future. There's a new version of it coming out that has a longer half-life, so it may actually be a nicer drug to use than iloprost itself. But it's another alternative for nitric oxide in terms of being able to deliver drugs straight to the lung bed. So those are inhaled ones. The other ones that we see in the ICU, of course, because oral options are not as easy to give in the initial postoperative period, is IV options, which we have to be very careful with the IV options because now you're delivering a drug to the blood that's going to then help dilate the lung bed, but subsequently it also dilates the rest of the vascular beds. And so you can imagine that results in pretty significant hypotension if you're not really careful with it. And so those drugs, we have to be quite shy and a little bit use them very cautiously, knowing that it can come with a lot of hypotension, which doesn't help your kid out in the postoperative period. Some drugs that are used in the initial postoperative period include IV sildenafil, which in our center we haven't used a lot of. It can be given as a bolus style or an infusion. And I think other centers, particularly other NICUs, have been using that drug a little bit more often. IV prostanoid therapy, or prostacyclin therapy, which is Flolan, or epoprostenol is another drug that we look to. We don't use that in the postoperative period very often because, again, it's a drug that's associated with a lot of systemic hypotension because it dilates the rest of the vascular beds as well. So we have to be very cautious about it. That drug is used primarily in kids with idiopathic or primary pulmonary hypertension, where it really has to do with the vessels of the lungs that are abnormal and they've changed. So that's where you'll see that drug used more often because it's a chronic therapy that, again, we can initiate and slowly ramp up, which allows the body to adjust so they don't get as much hypotension with it. And we've had a couple of kids recently that have come in for initiation of that therapy. There's another drug in that group. I only want to mention it. It's certainly not a drug to use in the ICU in the postoperative period, which is Remodulin. And Remodulin is similar to Flolan, but its half-life is much longer. So it is not a drug by any means that's ideal for the ICU setting. It's another drug that kids would come into the ICU to get transitioned onto, because it's a really nice, long, chronic option for kids in the outpatient world. The other group is oral medications, which I've intentionally sort of avoided because oral options aren't really great in the ICU setting, particularly in the first 24 hours. after surgery, but certainly it is a very common group that we transition kids onto once, again, their guts are ready to work and able to tolerate oral meds. And good options from that, or more popular option, include sildenafil, which works again through the nitric pathway. A little bit different than nitric oxide itself proper, but again, that's the pathway that it's targeting. And so sildenafil is the one that we use the most commonly, or Revatio is what its drug name is for kids. Of course, the biggest thing with sildenafil is that you have to deliver it orally, and so it needs to be given by an NG tube. And another thing, it's another drug we have to sort of ramp up. We can't start at the full dose, and I think everybody here has probably had a kid where we've seen that. You've seen us start really low, and then as we get to therapeutic dose, then we can wean the nitric oxide off and just leave them on the sildenafil. Another group in that area, so different targets, so endothelial receptor antagonists, as we talked about, is that third pathway. There's no IV options for that group. There's no inhaled options, but there's an oral option, which is bosentan. And I just mentioned because it's another thing that you'll see us use as a second oral agent, because we're using a different pathway. A lot of kids don't get started on that really till they're on their way out of the ICU, because it is another medication that needs to be given by mouth and isn't as well tolerated. So that's sort of the groups of drugs. Really, the post-operative kids, we're looking at using the inhaled drugs and the conservative measures like we spoke about. And for the kids that come in, totally different from the post-operative kids, but those that come in with primary pulmonary hypertension, like the kids that we've had in the last couple of months, those are the ones where we're looking at chronic options, and that's where we bring in the initiation of flow and additional oral agents to help them up. And those are the kids that are starting really low and going up and up and up and up very slowly to try to get them stabilized. Any questions about, I think that's my time almost.